So Siddharth is
Yes,
here. We are, it's a pleasure to have you. Siddharth, please go ahead with your presentation.
yes, sir. Thank you. Good morning, everyone. Actually, I was planning to present a CTO case of RCA, but now I think this case I have done 2 weeks back only and very interesting case. So I thought I should present this and we can present that case in later in future. So this is a case of right subclavian vein occlusion due to clavicle bone fracture, and she is a very elderly lady and came from very far Manali. And see here you can see that the how hugely swelling present in the right upper limb, and she was 20-year-old female and she has history of swelling in the right upper limb since last 2 days, and she has a fracture of clavicle bone 1 week back only because she rolled down on at her home in the Manali because they are a hilly area, and because of that she sustained injury in the clavicle bone. And after uh, fracture, she consulted local doctor. They have given arm support and all. But one day suddenly she observed that I have some swelling. And next day when she woke up, then she said I have massive swelling in the right arm, and even I am not able to move the right arm because of swelling. She was a known case of diabetic since 15 years, hypertension, hypothyroidism, and these were almost controlled, not on the very serious condition. Like HbA1c was around 8 at the time of admission. So we examined the patient, and it was the pitting edema present in the right upper limb involving up to the shoulder joint. Whole right upper limb was involved, and pulse in the bilateral radial and brachial artery was equally palpable. So we thought that there is a arterial system is not having any problem, and blood pressure was also almost equal in the both arm. So we were sure that this is a problem of venous system. We further did the color Doppler. So it was suggested of complete occlusion of right subclavian vein in the color Doppler. So we consulted the vascular surgeon and the orthopedician. So orthopedician told that the HC is a very elderly lady, 70-year-old, and clavicle bone fracture is not very easy to fix. And in the 70-year, even it is more difficult. So they told that first we have to tackle this vascular injury, and after that we can tackle the fracture part. Vascular surgeon also told that as there is a swelling over the whole limb as well as the in the shoulder region over the clavicle bone there is swelling, and there is lots of neurovascular bundle is present. So if we open the whole the part, there is a chances of the injury of the brachial plexus and nerves in that area. So they were also reluctant to open the case. So we thought that we should try something for this patient. So this is the initial angiogram. Here we can see that we can see that there is a, sorry. Here we can see that there is a fracture in the clavicle bone here. And here we took the short from the femoral root. We have kept a marker from the right brachial vein through the coronary wires or as a marker. Here we can see that the subclavian is completely accurate 100% with lots of thrombotic burden is present. So, but other tributary of the subclavian vein was there patent, like the scapular vein were present. But here we can see that there was no flow in the subclavian vein. So we use the MPA catheter for diagnostic catheter for the venogram of this patient, and we use the J-tip thermowire. So further we cross the lesion to the extended thermowire, and after crossing the lesion, we can see that there is a large area of the diffusely thrombotic area is present in the subclavian vein, proximal part of the subclavian vein. From here to here, there is a complete occlusion. So we took the small balloon of 6 into 40 mm Mustang peripheral balloon and dilated the whole area. And after dilation, we see that there was a flow increased, but still there was large area of thrombotic burden part present, and the flow was marginally improved. So we thought that there is a large burden of the thrombotic, so we should give the catheter thrombolysis. So we use the LT-plus injection at the rate of 1 mg per hour for 20 hours as an infusion through the MPA catheter. We kept the MPA catheter just crossing the lesion. Here was the lesion from here to here. We kept it in the crossing the subclavian vein for 20 hours through the femoral roots. And also we give the heparin infusion at the rate of 200 injection per hour as in other route by the venous system, and keep the patient immobilized for the next 20 hours in the our CCO. So after the catheter thrombolysis, here we can see that the flow has improved very much and very less residual thrombotic lesion present, and vessel is also almost opened. But there was still some residual narrowing was present and little bit thrombus was present. So we thought that we will give the final dilation to this lesion. So we took the 10 into 14 strength peripheral balloon and dilated the whole lesion. Here we can see that there was little best was present. We did the 2 times the dilation of this lesion. And after the dilation, so after the dilation, we can see that the lesion was almost completely subsided, and the next day the swelling was almost completely vanished. So she was able to move her limbs, and the blood flow was completely vessel was completely patent the next 24 hours only. So from this case, we can see that the acute venous occlusion can be due to fracture after the any clavicle bones in this region. And if we did the balloon angioplasty, but balloon angioplasty does not work always if there is a high thrombotic burden. So if in initial 14 days, we can give that catheter thrombolysis by the LT-PLH or streptokinase for these kind of patients. And these patients will require treatment for primary cause like fracture of the clavicle as well as the subclavian vein thrombosis there are present. So we give the Novak therapy, and we will continue in the next 6 months at least, and we will see the how patient behave, and patients further sent for the treatment of the clavicle bone fracture. Thank you, sir.
Well, thank you. This was again a nice case. Venous occlusions behave differently as compared to arterial occlusions. So Siddharth has done a wonderful case where, and I think the strategy has been very good. He was patient. He did TPA for many hours, and then only balloon dilatations. He didn't rush in to have a stent. So I think this is beautiful. So I think this was a very good case, Siddharth. Very good case. You know, these things, our vascular interventionists do it very routinely because they are dealing with kind of dialysis, catheter occlusions, where the venous channels get occluded, and they keep on doing all the balloon dilatations repeatedly. So yes, this is a very good example how we can ameliorate the symptoms by opening the venous occlusions, and this is the best way which you have shown. You know, the anticoagulations, thrombolytics, and the balloon dilatations. Thank you, Siddharth. Karthikeyan, please, it's your time now.
Thank you, sir. Nice case, sir. We also seen with case of antiphospholipid antibody syndrome, sir. We had 2 to 3 cases. We have seen SVC occlusion. We have seen, sir, actually. So we did the same thing, sir. We parked the catheter across the thrombus, and we gave infusion for within a day, and usually it settles off, sir, actually. And a nice case, sir. Thanks for.
I agree with Karthikeyan. So this is the best way.